fire and emergency procedures that are applicable to the council house. Please can I also ask that you use your microphone when addressing the meeting and that it is switched off when you are not using it. Your mobile devices are turned to silent. Councillors are reminded that as of 19th of June 2025, Plymouth City Council has entered a pre-referendum period and members should follow the protocols as set out in the published pre-referendum guidance. Specifically, councillors must avoid mentioning or referring to the referendum in their speeches, discussions and debates today. The broadcast of this meeting will be stopped if this happens. Any queries relating to the pre-referendum period guidance should be directed to the monitoring officer. So, I'm just going to go to the agenda. Item 1 on the agenda, apologies. Jake, do we have any apologies for today?
Thank you, Chair. No apologies today.
Item 2, declarations of interest.
Will and I both work at the hospital, so is Maria.
Okay, thanks for that. Thanks, Ray. Item 3, appointment of chair and vice chair. Moving to item, it is asked that the panel note my appointment for chair for the municipal year with Councillor Ney as vice chair. Everybody agree with that? Okay, that's fine. It's already been approved anyway. Item 4, minutes. Minutes of the meeting that took place on the 11th of February 2025. Does the committee agree, the ones that were sat at that meeting, agree with the minutes from the last meeting? Do you all agree? I mean, I know, because we've got some new members today, so Andy's new, Tina's new, Alison's new. So Maria, can Maria propose, and can we have a seconder? Either Will or Ray, it don't really matter. Yeah, thank you very much. Item 5, chair's urgent business. There are no urgent, there's no items that are urgent. So, item 6. So, quarterly performance, finance and risk reports. I'm going to go to Stephen and then we're going to go to Helen.
Thank you very much.
Sorry. Before we even go to Stephen, I'd just like to say this is Stephen's last report for us today, or last scrutiny meeting. I don't know when are you actually leaving?
Next week.
Oh, so
Next week.
Right, okay. I'd just like to say thank you to you, Stephen, and I know Emma is also leaving. I don't know when Emma's going. Oh my God! So they're both going at the same time. I'd just like to say thank you to the both of you. You've worked really incredibly hard on this scrutiny, and for the last 2 years, 12 months, whatever you've been here, and I'm just very, very grateful for all the hard work that you've done. And I'd just like to wish you both every success in whatever you're going to do next. So thank you both so very, very much.
Thank you. That's much appreciated, and I've enjoyed working with you. And that I have. And let's see. Ask me again at the end of the meeting. So thank you. We've shared the latest quarterly performance report. It's in your pack. Since we last came in, I think it was February, we've been working on an improvement plan and through our transformation board on a number of areas, with our primary focuses being around waiting times for assessments, waiting times for annual reviews, practice development, and a focus on OTs. And Ian will talk you through some of that in more detail shortly. But we have seen improvements in waiting times for assessments and reviews, which has been really positive, which hopefully you will see in the report. We've also now had our CQC inspection, which took place in June. Their site visit was in June, although the process actually started in January when we did our information return. The CQC inspection visit was a positive experience in as much as it went really well. They were able to talk to a whole range of staff and providers, partners and councillors, including Councillor Aspel and Councillor Murphy, which was great. We don't get our report back from them for another month, 1 or 2 months or so, but I think your initial meeting is with them next week, Gary. We're looking forward to their feedback. And we think it went well in terms of they were curious about the things we expected them to be curious, and hopefully we were able to demonstrate some real strengths as well as, and we were also able to demonstrate areas of improvement that we were working on, and were able to evidence improvements that have been made. So we're not going to take you through every slide and the pack in detail, but if you have any particular questions about any of them, then we're more than happy to take them. As I said, there have been improvements in the reduction in waiting times for assessments and reviews, and also an increase in the number of people who receive direct payments. Ian is going to take you through in a bit more detail the work we've done in relation to our waiting lists over the last few months.
Thanks, Stephen. In my slide pack, it's slide number 4, but I don't know where that is in your pack, which is the Care Act assessment slide. So this is mostly good news. When I came to speak to you before, we had some people waiting over 500 days for assessments. Now, while we still have some over 300, that's come down significantly, and that work will continue. So at the time of speaking compared to the time of writing, I'm anticipating that we will be under that 300 now. So that's really good news. We didn't have high numbers, but there were still some people waiting far too long. So that's come down. If you look at the number of people waiting, if you can see the graph on the top, that has also continued to drop really quite healthily. So we're really making a difference in terms of how many people are waiting for Care Act assessments. A lot of the catalyst for that work started through some test of change work in our south and our east localities. So our teams are split into south, east, north and west. That involved the whole team, the social workers working with the manager on identifying all of the reasons why things were getting held up, stuck. It revealed lots of things that were quite fixable. We had a really good manager in that team, and we've seen a significant improvement in that locality compared to the other, if you like, the control locality. And so we've now rolled that process out to the other localities as well. So all of that's been done as a consequence of quality improvement is probably the message, rather than more resources. There are no more people doing the work, but what we're doing is working more effectively, and I've got a better understanding of what it is that's holding things up. So it's on a good trajectory. And on the subject of trajectories, we've now got our the time we anticipate when we're going to be within range of what we consider to be a reasonable wait, which is something else that was asked before. When will we be where we want to be? So we're anticipating that will be in October. We'll have a waiting list which is reasonable. Now, the data since then has gone slightly in the wrong direction. So we're going to be reviewing that trajectory, which is what we have to do, because there's lots of things that can come and sort of impact that. But as it stands at the moment, we're still on track to do that. So that's all largely positive. The final thing to mention on that is that we've also analysed the outcomes from assessments in a bit more detail, and a very high number of people, having gone through that full Care Act assessment, do not require a funded care package at the end of it. That doesn't mean there's no value to the process, because a whole part of the Care Act is giving advice and information and signposting, but that suggests strongly to us that at the front door we are missing opportunities to put people in touch with the kind of support that they need earlier on. So I'm working very closely with the Wellbeing Hub network in Plymouth. I'm part of their group now. Myself, not Stephen beyond next week, but Gary and colleagues are going to start a piece of work to look at what we can do differently at the front door, as we call it, because the evidence and the auditing suggests there's opportunities, and our locality teams, who are the teams that pick those cases up from the front door, are also saying, actually, if we'd provided a little bit of signposting, or if we'd made the person aware of that service, we could have avoided them being on a waiting list for as long as they were. So that's the next area of focus. And on the subject of waiting, we have now implemented our waiting well policy. I think we just implemented it last time I came, but we're continuing to use that. That involves text messages going to people as well, proactive follow-up to make sure people are okay while they're on the waiting list. So quite a lot of progress, I think, since we came before. Still more to do. The next slide shows our progress on reviews, where we've seen a slight backward step, but not too much, and we're still aiming to be within the regional benchmark position, which is 60.7% of people having a review within a year of having their care package put in place. We're currently at 57.9, which is a significant improvement from where we were. Also of interest for the people that go over that year, we haven't got anybody, he says, just looking at Stephen to confirm, that have waited more than 2 years, which we think is also quite significant because it's not uncommon for some local authorities for people to wait a lot longer than that if they haven't got a proactive mechanism in place for chasing up reviews. So our central review team keeps an eye on that as well. So reviews and assessments, positive. For slide 6 in my pack, which is occupational therapy, not so positive, but also not a deteriorating position. There's been a very slight improvement in the total number of people waiting. I've got exec lead responsibility for the combined OT and physio waiting list improvement work, which we're running within LiveWell. Already within that work, we've done some extensive demand and capacity modelling. So we've looked at how much we think OTs and physios ought to be able to complete, how much work is reasonable. We've used national tools to try and benchmark where we are. Similarly to the adult social care, the wider piece at the front door, we're also looking at whether we are identifying too many people as needing an assessment. Perhaps there could be a quicker opportunity, a quicker offer of support as well. But we're not in a position yet to have developed the trajectory that we have for the Care Act assessment. So that will be the focus for the next period of time. So I'm sort of where I was a few months ago with the Care Act assessments. I'm sort of there now with the OT. So we're getting a much better grip on it, focusing on demand, capacity and productivity. But the next step is to really start to define that improvement trajectory. And that will also link to what we've called the front door, the sort of improvement piece around the operating model. And just a final example of where we are already seeing some success. LiveWell's got a partnership arrangement with Plymouth Community Homes, and we've joint funded some trusted assessor roles who are able to take cases off the waiting list, go out, simple adaptations and pieces of kit that they can deal with themselves. And that's contributed, I think, over 100 cases have come off the waiting list through that arrangement. So we're going to be looking at whether there's more we can get from that as well. And the more we can work closer with our wellbeing hubs and our VCSE partners, I think there'll be more opportunity as well. So those are the three main areas I was going to cover. There is a sort of slide right at the end just mentioning our discharge performance, which has got P1 written on it, just again to avoid any acronyms. Discharge pathways from hospital, what would have previously been called complex, are differentiated between pathway 1, which is people who can go straight home but may need some support, either through a care package or some intermediate care reablement. Pathway 2, which is somebody that needs to go into a sort of bedded 24-hour environment prior to then going home, so they might be too poorly to return at that point, but they go out in the meantime. And pathway 3 is a very small number of people who are not able to return home, likely indefinitely, have got significant long-term or end-of-life or nursing needs. So P1 is the pathway home, and we have a target to try and increase the number of people that go through that pathway to 75%, because it leads to far better long-term outcomes for people. The longer somebody stays in hospital, usually the less positive the outcome can be of being spending too much time in bed. So we're making good progress there, and the overall criteria to reside, which is this sort of the measure of how effective we are at discharging people in a timely way, is pretty much on track for Plymouth as well, which is really important for us. And that was it for me.
Thank you. Before we go on to Helen, has anybody got any questions? Andy?
Thank you, Chair. You say the OT department's highly stretched. What efforts are being made to recruit new OTs to the profession? And also, could you explain more about the collaboration with Plymouth Community Homes with this trusted alliance model? I don't understand that at all. Thank you.
No problem, yeah. So on the recruitment point, we, in Livewell, we aren't holding vacancies. We don't have a lot of OT and physio vacancies within our structure. The issue is therefore that the current volume of work we're asking them to pick up is greater than the number of therapists we have. Caveated by my comment earlier that there is a possibility that some of that work could be done by people that aren't OTs. So more simple equipment queries and such like. As it stands, that's the issue, that's the mismatch, if that makes sense. There are other avenues in which we try and bring OTs into Livewell and the profession working with the university, but in terms of this issue, it's not about vacancies, it's about the current demand is not equaling the resource we've got. But as I say, that's the focus of that front door piece. And it does link to your question about the Plymouth Community Homes. So as obviously a housing provider, they're in a very good position to be able to make small adaptations to properties and work really quickly with us. So we're not talking about through floor lifts or anything like that, but very simple things that would otherwise potentially get on a waiting list and stay there for a long time. We've got some pilot roles that work really closely with our front door and allow us to task those individuals to go out and fix things really quickly. As I say, it's been very successful, and we're going to explore whether there's anything more we can do there to scale it up.
Just following on what Annie said, with PCH, have we got that working relationship with any other social housing landlord? So like we've got Live Well or Live West, and we've got Sanctuary, we've got Sovereign. Do we have that sort of working relationship with them?
So from Livewell's perspective, we have a partnership arrangement with Plymouth Community Homes, but I would expect yes, the Plymouth Alliance has the same arrangement with the broader social housing providers.
I mean, it's great to see that those waiting lists are starting to go down, and I can see like the number of waiting lists dropped to 700. Is that because of the work that's being done, or is it because there's no need for those people to be on that waiting list? Because what I don't, in my head, I don't get, we've dropped the waiting list, but the wait times and the mean wait days have gone up, and I just don't get that, if that makes sense. Because if we've dropped the waiting list, how can the maximum waiting days go up and the mean waiting days go up? Am I just being thicky or something? I don't.
My understanding of it is that because of how our data is captured, it will apply a retrospective timestamp. So as we're catching up and closing things down, I expect it's pulling the average up, because we've had people waiting for a very long time. Once we close it, then it temporarily gives you almost a false reading, because until what we don't have is live data in this report. This is all stuff that's closed. So as we're starting to catch up with people that have been waiting a long time, once we close it, their average lifts the overall average, if that's making sense. So there'll be a period of time when it will be longer, and then it will come down again.
Okay, I understand what you're saying there, but that's dated back in May. We're in July now, so if at our next scrutiny, then we should see those numbers dropping. Is that what you're saying?
I think if we came back to the situation we were in, where we had some people for 500 days, they've been open. Now we're down to 300 days. There's quite a long tail on some of those cases. So we could start to see this effect continue for a period of time until we get to within a position where we don't have that length of wait. So it is something we could look at with our sort of data analyst as to whether we can do some modelling on that, with making a projection as to what we think will happen to the averages. But I wouldn't want to say by the time we meet next it will have evened itself out, because I just don't know. But that's the phenomena, if you like, that you're seeing in the data.
And just to say, because I think you're referring to the OT weights, but if you look at the assessment weights, we're now recording the average number of days it takes for an assessment to be completed from start to finish, and it's around 24, 25, with a target of 20. So it means that for new people coming through, this is on slide 4, that we're actually responding much sooner after we've received the referral.
Could I just ask you something, please? Just with regards to the OT, and you said the words "we're holding posts." Does that mean that are we on a recruitment freeze, or you can't recruit? What does that mean?
No, apologies. I probably wasn't very clear. I wasn't holding posts. I said we're holding our own. So our waiting list isn't growing. It's staying stubbornly high, which suggests we're able to get through the demand that we've got, but we've got a large backlog of people who have got lower complex needs. So the way that we deal with the mismatch in demand and capacity is prioritised, basically. So if somebody needs something urgently, we prioritise them. If it's a much lower level, lower risk issue, then they're much more likely to wait for a longer time. And it's that group that we're exploring whether there are other options for them. So apologies, we're not holding vacancies.
Thank you so much. This is probably a bit naive, and you may have touched on it at the beginning. I just wondered, how does the 4 billion in the spending review filter down? Does any of it eventually reach Plymouth? Can you sort of say how it's being dealt out across the country?
We're still modelling all that at the moment, and with help from our external advisor, so I don't have an answer for you quite yet. Is that okay? You mean for the spending review that's upcoming for next year, for 26, 27? Yeah.
Yes, I just wondered how, whether there was any input from us or we just wait.
So we'll be going back on the consultation about all the changes that, and that is due August the 15th. So we're just working on our consultation response now.
I've got a question about people requiring support out the area. Do we know what the maximum distance that is that people needing support out of the area is, and what impact that's having on the individuals and their families?
Are you referring to something on the report? Can you just
On the adults, the key facts. Because I'm just wondering from the assessments if anybody has to have help out of the area, how that's managed.
So I'm just looking for the particular thing you're referring to, but we do, I mean, we have got, is it in the?
Shall I?
Yeah,
help? You'll find it, Stephen, on
Yeah,
page
got it.
14 of the pack, and there's just some social care key facts. There are two main reasons for people being out of area. One is around choice, where people choose then who were a Plymouth resident but make a choice to perhaps go where family are, perhaps families have moved and changed, and they'll go and receive care there. And if you move into residential homes, for example, there's still a duty on us as the responsible authority to fund them. There will also, and that I would anticipate being the most significant portion of that 198 people. There will also be some people that maybe didn't have a choice and we couldn't provide a service. Now, I can't tell you what those numbers are. Those numbers are things that we can look at if that's what you'd like for a future scrutiny. But those are the two main reasons that people.
And also, some of them are just over the borders in Devon, Cornwall, Torbay. But there are some people who are further afield for the reasons that Gary says, because their needs are more specialised. We had to provide that data for CQC, so we've got it, haven't we? We can share more detail on that.
Thank you.
Alison.
Yeah, can I ask, you touched on it about the waiting list for social care assessments. So you said a lot of them don't result in a formal package of care. What does that number look like? Have we got data on how many actually result in formal care?
Yes, but I would be relying on my memory if I gave you a number today, and I would like to go and check that out. So I could give you what I think the number is now, but it might not be correct unless Stephen has got the correct number available to his mind immediately.
I've actually been given the percentage overall is about 20%, which is really low, but that includes people who we are involved with who are leaving hospital who might have a short-term service through one of the pathways, but not a long-term, not long-term support. So it's kind of skewed by people coming out of hospital. So it'd be useful to provide a figure for, I've asked for it actually, for the number of people based in the community, not hospital, who have a Care Act assessment, which will be higher. But I think, as Ian was saying earlier, what we're trying to do is do the work at the front door, is provide as much support as we can to avoid them needing to have an assessment in the first place if they don't actually need a service.
And I'm pleased to say that was the number I thought it was, so that's good. It was 20%. And what didn't mention this earlier, but we also looked at a sort of subset of service users with mental health presenting as having their primary support reason was mental health. And that the number that then needed either a direct payment or a care package, and that was even lower. It was just shy of 10%. So we're already in the process through the transformation meeting that Stephen mentioned of introducing a pilot that will try to support those individuals into an appropriate support, which is very often talking therapy or emotional skills or things like that, rather than going into a care package, because the vast majority of people have got the ability to recover, learn new skills, and not have an impact on their lives in the long term. So yeah, it's also slightly more marked for certain people as well.
So that waiting list could come down quite drastically, quite quickly with this new approaches.
And with closer working relationships with our BCSE partners as well, particularly through the wellbeing hubs, I'm already having really productive conversations with what they think they can do to support as well. And I think the more we can look at that together, literally together, ideally through a wellbeing hub, I think the quicker we can sort of say, actually, you don't need full care access, but this great service here can support you to what you need.
Thank you, Chair. I just want to pick up on some of the narrative around domiciliary care in regards to some of the regulated care providers that have some cause for concern. I wonder if you could explain a little bit about what those concerns are, what some of the common factors might be that are coming up, and what we're doing to put them on a pathway to improvement.
I can't go into the specifics, although it's more Emma's domain actually behind me, but there'll be individual related to those individual care providers, what the concern might be. It might be related to the quality of care or a particular incident or about the way that organisation is running its care. But they have any concern like that our commissioners will be working really closely with the care providers, and any safeguarding concerns we would be undertaking a cold service review through our safeguarding process to ensure that they are safe and appropriate decisions are made, as well as working alongside the Care Quality Commission. Sorry, not behind me. You were behind.
Yeah, I've just moved. So we have a what we call a provider of concern process, where every 2 weeks commissioning managers meet with safeguarding colleagues to go through the list effectively of providers we're worried about. We also meet quarterly with both representatives from the CQC and from Ofsted, again to triangulate what we know. Common themes are usually around leadership and management, around stability of the workforce, and those will tend to be the things that will tip a provider. We do try and work really collaboratively with them to help them improve. Quite often things are beyond their control, and we will try and wrap around them to support them. We also have our contractual levers in the event of poor quality, so we will use those where we need to as well. So there's a whole range of things that we do. We do genuinely try to do it through a collaborative approach, but we will step in more forcefully if we need to.
Any more questions? No. I'm just going to go to you, Helen.
So I'm just going to give a verbal update for month 2. As you'll appreciate, it's very early in the year, in the financial year, and we are reporting a nil variance on adult social care budget. What I realised as I sat here is you've got some new members, so for next time I'll do a kind of a breakdown explaining how the adult social care budget works, because it's quite unique compared to the other budgets. It's the biggest revenue budget in the council, at £113 million. But at month 2, we have been looking at our sort of our riskiest budget, so our care package expenditure. Sorry, my screen just turned off. What that's showing us is there is risk currently on our dom care budgets, which relates to volume increases in number of clients. And on our residential care budgets, there's also pressures, but that is not relating to number of clients, but the cost of packages driven by the complexity of need. Those of you that were here last year would remember we had some pressures from our income budgets. At budget prep, the income budgets were rebased, so we're kind of hopeful. We, at the moment, aren't expecting significant pressures on those budgets, and possibly that they will offset some of the pressures we're seeing in the expenditure budgets. In terms of saving targets that were assigned to adult social care for this year, there was about £2.7 million saving target in the 25-26 budget. Of that, we've already achieved 1.175 million, and there are plans to achieve the rest during the year. So that's what we've banked at this point. It's really good. At month 3, we monitor all of our budgets on the quarter, so there'll be more information for you. We have already set up, as we do every year, our budget containment group, where we're working with our colleagues in LiveWell to identify areas that we want to focus on, and then we will have breakout groups targeted to look at those areas in detail. So obviously the areas I just flagged, dom care, residential care, we'll be looking at health funding for client packages, and also looking at the impact of working age adults compared to older age adults on the budgets. So yeah, we'll have a lot more information at month 3 for you. So I don't know if any had any questions.
Thank you, Helen. I mean, that's a really, really good start to the year. I'm really impressed, I've got to say. You know, we talked about this at CQC about budgets and stuff, and we all know that people are living longer, and that really puts a pressure on council's budgets. But it's like I said to CQC, if it means us going over budget, but we've made sure that that person down the road has got the care and the help that they need, then I know which way I would be going. So, but thank you very much. I really do appreciate it. Right, we're going to go now to, and we're just going to note that report. We don't have to vote. We're just going to note it. We're going to go now on to item 7, palliative care and end of life. Palliative and end of life care. Mary, would you like to introduce this one?
Thank you, Chair. We'll just get everybody resettled. I might need to move down one to allow. Oh no, we're all right. We're okay at the moment. Right, great stuff. This has come to you, Chair. If you remember, we had a motion on notice that came to the March council meeting, and because of the complexities, I really felt it should come here rather than a debate where we haven't got answers, etc. So I'm pleased that we've had time now to put together the bits and pieces. So whatever we discuss today, can I ask us to think about the original motion on notice, as well as a letter from Councillor Beer that she sent in as an addendum between that meeting and this meeting, as to how we look at this and whatever. So I'm grateful for Chris to join us. Yeah, Trish, isn't it? Trish, the line was there. And we've got a starring role on screen there as well. So, all right, welcome. Okay, so I'll hand over to Chris.
Thank you, Mary. So thank you. As Mary said, we've pulled together an update to Scrutiny. So we've been a couple of times since the original conversation that we had just over a year ago now. So what I've pulled together today, you'll see within the pack that I'll just take you through the slides on, a little bit of an overview in terms of some of the updates on the improvement plan that we'd talked through previously, and some of the progress we made around that. An update on one of the key performance metrics that we've got, and then hopefully Laura's joined us on screen as well, I can see on mine, who will talk to us a bit about some of the work that Derriford Hospital and UHP have been undertaking around end of life. And then similarly, Trish will update us around some of the work that St Luke's have been doing too. So I am moving the slides, but they don't appear to be shifting on the screen. Don't know, Jay, have you got them to hand if you want to share them before I come out? Might just be my connection.
It's a mystery.
It is. If you want to go straight to slide 3, that'd be great. Thanks, Jake. Thank you. Yep. So as I say, we've continued the work since we last met, looking at our delivery plan for end of life, particularly within the locality, so within Plymouth. We've got the end of life steering group that covers Plymouth and West Devon, and we've continued to meet regularly in order to drive forwards the actions that we'd agreed last time. That then links in with the Devon end of life work. So there's a big programme of work within the ICB looking at how we improve end of life experience for individuals living within Devon. And the Plymouth group links directly into that as we're looking to take forward some of that work. If you go on to the next slide, please. So this one here, this is the plan that we'd previously shared with you, and as you can see, a sea of green this time, which is positive. Still lots of work underway that we need to take forwards, but the first one on there was looking at how we developed an end-of-life register and used some of the online electronic resources that we had available to us. That programme has actually broadened quite a bit now. We're looking at developing an integrated care planning system across Devon, linked into the summary shared care record. That's something that we're doing across the southwest region as well. So there's quite a good piece of work that we're at the forefront of within Plymouth in terms of taking that forward, so that will link into. So that's moving forwards. The next item on there was around looking at how we had a central information point for individuals and system partners for individuals who are on an end-of-life pathway. And Trish will talk a bit about some of the work that St Luke's have done around the Care Coordination Hub shortly. We'll come on to that. The next item was for us to undertake some demand and capacity analysis around end-of-life care, looking at the assessment of needs and the gap analysis. So that has been completed, and that's formed part of the Devon commissioning plan that's being taken forward to now. And then the next one was looking at, again linked to that, the options appraisal as to, once we'd done that demand and capacity work, what was the services that we needed to put in place, what were the improvements that needed to be made. So again, that's part of that broader piece of work that's being progressed too. Then we were looking at how we used audits of care in order to make sure that we're meeting the priority needs of individuals. So again, that's something that was completed last year, and we've got a continuing process in place around that now. And then the one there around specialist end-of-life support. So again, that links into the end-of-life coordination hub work that Trish will talk about shortly. The end-of-life care communication and training resources. So you'll recall we were previously talking about using an electronic system called Hive in order to develop that. Fortunately, that didn't quite meet the needs that we had for this particular area, and through some of our conversation with, particularly with care home providers and domiciliary care providers, it was really clear that that wouldn't necessarily quite have the impact and wasn't the support that they really needed at this time. So we've shifted the resource and the funding that we'd identified for it to instead support some broader management leadership training alongside Plymouth City Council into the care market. So again, positive in terms of responding really to where the need was identified by those providers in the local market. And then the last one in terms of developing the strategy for how we build on deaf literacy and encourage people to talk about deaf planning. And again, linking that to the Compassionate City programme that Plymouth is part of. So that's something we continue to work through, and we continue to have that through the local steering group. And actually it's something that Plymouth is recognised as a real exemplar. It stands out in terms of the work that's been undertaken to date. The next slide, please. Thanks. So this one, the very colourful top line with top graph with the lines on, the lowest line that you can see there, I won't even try and guess what colour it is, but the one that kind of dips down at May. So that line are the number of deaths that take place in Derriford Hospital each month. And you can see the very bottom, the lowest line is the numbers for this year. So you can really see that we've seen a significant reduction and a continued reduction in the number of people who are dying in hospital. Laura will speak shortly about some of the work that UHP have undertaken, but as a top line metric in terms of us supporting people to die in their preferred place of death and not in hospital, that's kind of a really good indicator for us that we're certainly moving in the right direction. There is an awful lot more that we need to do to understand how we're truly meeting people's needs and getting them to the place that they want to be. And we're continuing the work in terms of thinking about how we're capturing that and how we're reporting that. But wanted to bring this one particularly just to kind of give an update in terms of the progress that we're making around that. Next slide. So I'll hand over to Laura now to talk a bit about some of the work in UHP.
Hi there. Yeah, my name's Laura Daniel. I'm the interim cluster manager for UHP, and end of life is part of the cluster that I work within. So as Chris has highlighted earlier, I haven't been to one of these meetings before, so I don't know how much you've heard about the pathway previously, because I think that Shane was presenting at the last meeting, but if I start from the beginning, then I know what we've covered. So we had embedded an end of life pathway that extended out to our Mount Gold site, which is one of our community hospitals. And the project looked at us expanding into reaching a 12-bedded pathway. We are at full capacity now within that 12-bedded pathway, and we try to run at an occupancy of around 90%, so that we're always in a situation where we have one bed available so that we can support patients being brought down from ED quickly to a better environment than being within the acute environment, should it be required. We've taken about 420 patients through the pathway since it started as a pilot, and it's had really positive feedback. So you can see from the graph our occupancy and our capacity has grown as the project has gone on, and as I said, we're currently now at 12 beds within that space. Our length of stay does vary, and it depends which patients come into the pathway, but we've tried to widen the scope so that we're not just supporting patients just in the shorter time frame, but also looking at patients that may have a slightly longer requirement around being supported, because we recognise that our environment has such a positive impact on the patients and the families of those patients as well. So we have been successful in integrating Marie Curie into that space as well. So the teams are working really collaboratively together, and we've got really good communication methods between our acute team and our community team in terms of capacity, availability, what it's going to look like in terms of being able to support more patients coming down to the pathway, and also managing acuity within that space, recognising some of the limits we have around medical cover. So that forum and communication has been set up really effectively and now works quite seamlessly in terms of understanding when we're likely to be able to support somebody new from the acute, or when we're kind of at capacity for a little while. And the integration of those staff groups have been really positive. We've also brought them into our governance as well, so there's quite a lot of support and scrutiny around, are we doing the right things? Could we have learnt from anything that's happened with supporting those patients? But primarily the feedback within all of that pathway has been really positive, that the environment and the support that the patients and families get is a really positive one, and the staff also find it really rewarding to work in that space as well. So the other part of my role is also supporting the PIT team within the acute service. So they've successfully 2P'd across, and we're now kind of working on how do we operationalise that team most effectively. And if we go on to the next slide, that will talk more about the acute changes that we've made. So in this top slide on the left-hand side, the small wedge is people that have been discharged from an acute setting. The bigger wedge is people that have been discharged outside of an acute setting, which is showing how successful we are in pulling the patients down and away from the acute at the moment. And then the bottom slide is about how many patients the different parts of the teams are working with. So at the moment, the team works with 3 different cohorts to it. So we have a Marie cohort, team, which is called the PIC team. We have an ED team, and then we also have the inpatient team. So you can see that we're working towards trying to have more input with more patients through all of those pathways as well. The Marie Curie team were supposed to operationalise in October. There was a bit of a delay in that space. That was based around recruitment and retention, and also some aspects of operational delivery, which they hadn't really accounted for. So they had initially proposed that they would recruit a team that would work across both the acute and the community hospital sites. When that played through, they had to work the teams in a slightly different way. So we are getting closer to our trajectory in terms of the amount of patients that they're identifying and working with, but that is still work in progress. The decision was made operationally that we needed to stabilise the Mount Gold aspect of the pathway initially, because the Marie Curie aspect of that team was so pivotal in delivering that service to a high level. And now we're working on stabilising the acute aspect of the team. So hopefully we'll continue to see that trajectory moving forward towards the objective of, I think it's 52 patients a month. I'm on a very small screen at home, so I can't see the numbers very well. The ED team are doing really, really well in terms of trying to support patients from being prevented to even convey to ED, and we're trying to focus on that as the next part of our service development. So we continue to support them working through PDSA cycles of improvement so that we can track where we've come from and where we're going. And then the other things that we've been focusing on as well is looking at the ETEPs and really embedding that in terms of trying to have a focus trust-wide around ensuring that they're completed in a meaningful way. And we are seeing positive feedback in that space as well. Don't know if Sharon, you're after me or
Laura, sorry, it's Mary Aspinall here. There's
yes.
a few four-letter abbreviations here that some of our
Yes.
colleagues, especially the new ones to the thing, will not understand. PIC
Yep.
for a start, and also PDSA. I think most of us will think about that as an animal.
Yeah.
So there's that as well, please.
Yeah. So the PIC team is they're the palliative, and I can't remember what the I is. Palliative something care team. So they want it. The I always throws me off, but they are the team that are looking at in terms of supporting patients within the acute service. They help us to identify patients that may come down to Mount Gold on the pathway, and they also help us to identify patients that need further support being discharged out from the acute system as well.
I think
And then
it's going to help with the PIC there.
Thank you.
It's the Identification, Care and Transfer team.
Thank you. And then PDSA is Plan, Do, Study, Act. So it's just the framework that we use around improvement cycles within the system that we're working in.
Thank you.
Yeah, hello, colleagues. Nice to be back with you again. So this is, I think, my third visit to reviewing Scrutiny. I can say it's been a real pleasure. Somebody new to Plymouth 3 years ago. It's really quite phenomenal the amount of work that partner agencies have really done on end-of-life care. So I think partners in the room and yourselves are to be credited for prioritising this aspect. So this is somebody for whom hospice care and end-of-life is part of my DNA. It's been really fabulous to see the work done down in the southwest, coming from Gloucester previously. So you'll see that our little bit of the puzzle is the offer of the coordination hub, which when St Luke's went to consultation 18 months ago now with the public to say what was the most pressing issues for us, everybody said it was trying to navigate the system. And I think us in the system would echo that we too have lots of problems in navigating the system. So the ideas and the first thoughts then about trying to be that pivotal point of a one phone call where you could have a human response, not an automated response, to listen to your problems and concerns, hear them and may not be able to answer all of them, but at least let the caller know that we are hearing you, we will find a resolution. So that's the huge step that a very small hospice chose, that we would both put our designated funds into piloting. So you can see we went live in April. The role of the coordination hub is exactly that. It's to try and give a coordinated approach, not as St Luke's going to answer or respond to all, but we will try and find the right person in the system to best support patients and families. It's also trying to make sure that, my colleague at UHP quite eloquently said about all the fabulous work going on up at the Acute Trust, but our ambition is that we should not be conveying anybody in the end of life unless it was absolute that the quality of their life would be improved by having an acute hospital admission. So trying to prevent any conveyancing. We see one of our key performance indicators as only reversible impacts should be conveyed to ED, and that a St Luke's rapid response team will do a 2-hour response. In fact, it's much quicker than that currently. They've SWOST at the bedside and have identified somebody's in the last phases of life. Then we have a rapid response team that will go out and coordinate and try to maintain that patient in their preferred place of care at home. So the service can provide support and advice to rapid navigation of end-of-life services, shared decision-making and specialist advice, because obviously we've got our fabulous palliative consultants in the inpatient unit up at Turnchapel. We have advanced nurse practitioners who are non-medical prescribers. So again, advanced nurses with end-of-life expertise and disease management. We clarify TEP discussions and decisions. So if a treatment escalation plan either has been started or is due to have that conversation, then we make sure that it's a key part of our offer is to have these conversations with patients and their loved ones to understand wishes for their preferred place of care and death. And then, of course, we do obviously general advice and guidance and support, like I say, SWOST and ED colleagues. Obviously, we're very proud that the St Luke's hospital team that were trooped across to UHP in October, we're still very closely aligned with good relationships, that we speak to them on an ongoing basis to make sure that we're aligned with what the offer is. The first 6 weeks, so this was additional information, but the first 6 weeks of going live, the coordination hub saw 319 or had calls from 319 patients or loved ones. Vast majority of those were family carers, shortly followed by patients. We had district nurses and GPs, and at that point we weren't live with the SWOST, but I reliably informed by my hub coordinator that SWOST, we speak to SWOST on virtually a daily basis. So the calls to the hub from the ambulance control services has greatly improved. So.
Can I just say, like, we brought this to Scrutiny 12 months ago, and what we're seeing today is absolutely fantastic. The improvement that we've seen over that 12 months, all I can do is just thank you all, because it has been incredible. And I know we've brought this back today because there was a motion of note was brought into council by Councillor Terry Beer, and as members, you've all got a copy of the statement that Councillor Beer actually sent to us today, because Councillor Beer and Councillor Nicholson, who seconded the motion for whatever reason, can't be here today. As much as I sympathise with Councillor Beer on what she's written on this brief, it's historical. It's not what is happening. This is, I mean, we're going back to COVID period, and I get it was an emotional time, and it's an emotional time for anybody that has to go through through losing a loved one, and I suspect that there's probably members that sat in this room today that have probably gone through the same as what Councillor Beer has gone through. Because I know I have, and I'm sure there's probably other people. And that was the whole reason why we brought end of care life into this scrutiny, because we knew that it maybe wasn't up to what it should have been. But all I can say is over this 12 months, the recommendations that we gave you at that very first meeting, you've adhered to, and I can't thank you enough. On this statement, it does say, and I wish that Councillor Beer could have been here today, it says that end of life is failing. And although partners will sit before you and tell you that it's right, it is far from right. I've got no evidence, clear evidence, no evidence. I've got it from past, but I've got no clear evidence for now that this is failing. So I'm just going to ask you outright, that statement that Councillor Beer has written, is that correct?
I'm happy to make St Luke's observation for members here today. We wish we could get it 100% right. We don't. We see cases regularly where there's been a late diagnosis, a late conversation, and therefore only days of planning that we have the opportunity to try and support patients and their families to make. And every time that happens, certainly at the hospice, we have a full learning event. I want to know the palliative consultant at UHP, what conversations we've had. So we pull all the health records. I'm saying it because I know we've done that only this week. A young mother with primary school children, and she came into the hospice on the Friday and died with us on the Wednesday. And I had a very distraught inpatient unit team. So we don't get it right. And when we have the late presentations, we do a full learning event with partner agencies, and that one that happened last week will be held. And I know Sharon from Livewell and her team from the GP practice, UHP consultant, palliative consultant that was overseeing the care for this particular young lady, will all be invited to do a learning event to say, we all have our emotional reaction to wanting things to be right for our patients, but we're paid to have very difficult and emotional conversations, and we are tasked with preparing the patient and the family to make memories in the short time they have left. So any time that we prevent a patient and family from having that opportunity, we absolutely take it and hold the system to account, ourselves and the system account. We're very much part of that. So, no, we don't always get it right. I don't know anywhere in the country that would, but I can absolutely give you categoric assurance that services in Plymouth are much better a year on than they were last year. And again, having somebody who managed the care home contract through COVID and was very much abandoned by health statutory services. COVID was an awful, awful time for all of us. And lots of lessons have been learnt. And we're a very long way from those very dark days.
I think I would second that from a UHP perspective. I think we've worked really hard to try and ensure that everybody gets as positive a experience as possible in a really difficult circumstance. Similarly, we don't get it right, but what we are committed to is learning from every instance that we don't get it right within. And we've got a high level of governance and scrutiny within that space for families and patients to be able to feedback when they're able to about their experiences. And we do really draw upon those as a learning opportunity about how can we develop things further forward for families so that they and patients so that they don't have to experience those same things again. The Mount Goal pathway is very close to my heart, and I do see the benefits of that every day and hear the benefits of that. And I feel that has been a very positive step forward in terms of being able to support people in an environment that is just much more suitable and comforting than being within an acute environment. So I am very, very proud of what we've achieved in that space. So I don't as we've said, I don't think we get it right every time, but we're committed to learning and growing in that space so that we continue to progress forward.
No, I agree. I mean, when you brought this 12 months ago, we knew that there was recommendations that we had to put forward, and you've done that. And if I'm being totally honest, I'm pretty sad that it's come to this. If I'm being totally honest, that the motion, and when we're looking at the motion, all of the things that I've mentioned on there are actually have been done. So I'm hoping that Councillor Beer and Councillor Nicholson will be reassured that these things have been addressed and they will, and they will continue to be addressed. I'm just, yeah, I don't really know what else to say on this, if I'm being totally honest. If we'd had clearer evidence of now, maybe we might be having a different conversation. But I think all of this has been covered on that motion. I think maybe Mary, it might just be a letter to the MPs to just ask them if they can lobby government, but we are doing what we are doing here, and I think we're very, very lucky for the dedication.
Can I speak? I think, having spoke to Councillor Terry Beer about this, she was really disappointed not to be here today, and she was hoping for a little bit of notice, I think, because she really wanted to be here. But I've looked at this, and I think we've totally missed it. She is saying, is there an integrated care pathway for palliative care? Are people that are given a diagnosis of palliative care treated the same as people that are treated of end-of-life care? So, for example, she's got experiences here from residents, and she's put down a personal experience as well. And for me, it's kind of like, are we doing an ICP for people with palliative care? Are we just concentrating on end-of-life care? You could go home, you could have palliative care for 6 months plus. Are we looking at them that they're having the same care as end-of-life care? Are we looking at nutrition? Do we have a care plan that has nutrition in it, mobility in it? So they live the 6 months of life that they've got. We're not looking at end-of-life care specific. And looking at this presentation, there's a lot of words on EOL, end-of-life care, but I don't see a lot on palliative care. So for me, I think this has not been answered. And that's just from looking at that presentation. Do we have an ICP for palliative care?
So the palliative care team do support in all of those spaces. The priority around ETEP and earlier identification has been something that's been really key, and has been a focus within UHP for a long time now. So what we're trying to do in that space is ensure that ETEP completion and advanced care planning and all of those conversations become business as usual, as opposed to a challenge conversation at the end of someone's life and not completed in a planned way. So I can definitely bring back information in that space if that's what you are wanting in terms of insurance. And I know that it's high on everybody's agenda, not just an isolated team in that space. But I'm happy to bring back anything that you would like around how we're managing that aspect of care planning.
Yeah, I think because the motion of notice is based on both areas, not just end of life. So I think, I would like to think that someone goes home into the community and they have a care plan for the palliative care side of it. I wouldn't like to think they're only brought in a care plan and looked after it completely 100% at end of life. I think that's what Councillor Beer is talking about.
Yeah, so I think we talk in two frames within the hospital, and it may just be the terminology that we've used within the presentation. So we do talk around end of life, we talk around last days of life, and then we also talk around the palliative care aspect of it. But if you want some more information specifically around the palliative care planning that's earlier in the phases, I can definitely provide that. That's not a problem.
I've got Angela, Maria, and then Will.
Thank you, Chair. I was also initially of your viewpoint that if, particularly if you look at the end of locality, at the locality end of care plan, and then all we've heard from Tricia, and you compare that to the points on the emotional notice, I think a little bit of writing it up would show that we really are on track to meet all those issues, apart, as you said, from writing to the MPs. So I think if you break down, especially in that table that you provided, everything is on track. And a lot of it, I take Carol's point, and what's been said there. So I don't think we're far off, and perhaps a little bit of work could be done to bring all the material together so it comes together with these points on the motion on notice. Wouldn't take a lot.
I already have put a declaration that I work at University Hospitals Plymouth and I am a cancer specialist. The motion did actually state end of life care, but we know that palliative care can be for a number of years. And as a cancer nurse, we support patients through that pathway. There's opportunity for holistic needs assessments throughout their trajectory, and there are also support workers working with the CNS team as well. So we do highlight where possible, where interactions are required. And the benefit of the hospital as well, and the fabulous thing that happened in March was the same day emergency care, where patients are seen and triaged quite quickly and needs are identified and addressed. So I think your coordination hub is for the last 12 months. So we've got quite a lot of the aspects already covered there.
Thank you, Maria. Will?
It's been quite an interesting. It's just a shame some of the work that we've done and when this has gone through, it's quite easy to people to listen back to the previous videos where all different partners came in. I think there's some reservations with the statement and how that's been included in the papers. I'm not sure I'd be happy that that statement remains in the papers. I think implying that people that come here don't, are going to lie or mislead us. I don't think people have integrity, and no matter what issues there are, the hospital's care is, whatever the ratings, but the care has always been rated good. And I think there are examples where people have been using the techniques. Obviously St Luke's work with people. There's the staff like Carol and Maria working through when people are diagnosed with illness, getting them to plan so they can plan the time they've got, what their needs are. People go on holiday and things like that, don't they? And when people are have been utilising those techniques to manage their illness and manage their relatives' illness and things, I think that's that's an outcome that is good in a way. So, I don't think I think the statement should be removed from the papers. There's a couple of things I know are not. I think doesn't reflect on how I have sat here and listened and learned, and I don't think that's fair reflection on other. It might be you have to listen to individuals' points of view, but that's not how I would approach anyway. Thank you. Thank you for your coming as well.
Has anybody else got any questions? Okay. This is the third time that this actually has come to this scrutiny, and as much as I do sympathise with Councillor Beer, Councillor Nicholson, I think we need to say, we've scrutinised this really in depth, and I think now we need to say that unless something is really evident that it is something that is absolutely going wrong, then I think this will be the last report that we have this year. Because there are other things that we really need to scrutinise. And so I think unless there is something that really concerns us, or we've got evidence that really, really concerns us with end-of-life palliative care, I just want to thank all of you for all of your hard work, because I actually do think you've really, really listened to us. When this first came, you sat there, you listened, and you've taken all the recommendations that we gave you into consideration, and you've addressed them. And I don't think we can ask any more than that, if I'm being totally honest. Maria.
Just a supplementary, you've already proved to us that you've got your own scrutiny processes in place, and you're looking at experiences where things aren't right to see how you can improve. So you're already doing that, you're already evolving and trying to make things better. I feel quite reassured by that.
I agree. So, I mean, Mary, obviously, this motion notice was for you to address issues on there, and I think probably the only one would be maybe just to write a letter to the 3 local MPs to see if they can get any more funding. But other than that, I think all those other items have been addressed.
Thank you, Chair. Yes, I'm very happy to write to the MPs and encourage them. And certainly from the times I sit on I'm an observer on the ICB board, I'm certainly, my ears prick up as to anything to do with end-of-life care. And I think it's got to be an essential that we keep an eye on. It's something that's going to happen to all of us, and we need to be making sure that whether it's the palliative care, because we have an ongoing illness that needs monitoring, that needs treatment, that needs that support, etc., for the patient and the family, and then those end-of-life days come the end. I think it's something that we all, as a civilised society, should be one of those things that we really work for, because there's nothing worse than hearing that there's been, if you call it a bad death, when there's all those people in the hospital system and in the palliative care system and in St Luke's and charities like that are prepared and will work willingly to make a death as comfortable as possible. But yes, there'll always be the odd occasional when we don't get it right because time has been against us at the last minute. And I think that to me is what is essential, that we need to be protecting our city and making sure there's the best service going out there. So I'm very happy to write to the MPs. And going back to bullet point 5, it's saying about the extra beds. I think that St Luke's have done their in-depth analysis as to what they need, and I accept that St Luke's are the best judge of that. It's not for me to be demanding extra beds. I think the whole idea of people die in the place of their choice is the right perspective, and the extra beds now that Mount Gold have been that extra addition, and I think that's got to be welcome. So thank you, Chair. I will with pleasure write to the MPs and see what they can do about funding. Maybe there's some of that millions that government have promised we can utilise. Thank you.
Yeah, I mean, we've also got to understand palliative care is not just about cancer. It's all illnesses. So, you know, if we look at that, it probably mentions cancer and whatever, but actually palliative care is all illnesses. It isn't just cancer. So we just need to bear that in mind also. So can I just thank you for coming today, and yes, and like I said, once again, congratulate you on the progress that you've made over the last 12 months on all of this. So thank you very much.
Thank you.
We're going to go now to item 8, which is the NHS reform and restructures, and I've got Peter Collins, but we've got Peter online today. So welcome, Peter.
Thank sorry. Thank you, Chair. Thank you, Chair. And for members that don't know me, my name is Peter Collins. I'm the Chief Medical Officer at Devon ICB, and I'm here to talk to the update paper that we supplied, which covers two items. The second, which I'm happy to take questions on, but is a matter of public record elsewhere, is the current financial situation within the Devon ICS and our approach to that. But more importantly, to update members and to take questions on where we are with our response to the government's signalled intention in March of this year to seek to abolish NHS England and to restructure particularly the organising and commissioning parts of the health service, including ICBs. So members may be aware that as a response to that, there's a requirement to reduce cost and therefore size of integrated care boards in line with a national specification, which requires smaller integrated care boards to consider aligning themselves and eventually merging with neighbouring systems. So in the last month, NHS England and the national team, including the Secretary of State, have agreed the proposed clustering of Devon, Cornwall and the Isles of Scilly ICBs into a single entity, which we will be seeking to progress. And as part of that, we're currently in the tough part of the reorganisation and describing structures, appointing new chairs, chief executives and executive members, and then looking at reorganising the structure of a single organisation to meet the needs of our combined population. More than happy to talk about where we are and to hear from members about what they would want to know more of in the future, and seek your support in continuing to reassure our public that from a service point of view, whilst we're making these changes, there should be no difference to the services that they are receiving in the short term.
Okay, thank you, Peter. Got any questions from members? Ray.
Thank you very much. Are there likely to be any delays in people getting treatment once all this amalgamation takes place?
My hope, Councillor, would be the opposite. In fact, I think the intention of the refining and restructuring of integrated care boards is to help us focus much more on the core business of strategic commissioning, which in my mind is about understanding data on the needs of our population and making sure that we are creating and holding service to account for delivery. So if anything, I would hope, and the aspiration of these changes would be that it will seek to improve services, not to delay them.
All right.
Are we likely to see an increase in funding, or will it just stay flat the same?
Very important question, Councillor. Thank you. So you will see that in the second part of the update, there is a description of where Devon ICS is financially, and recognising that at the moment we receive significant support funding from NHS England to support a deficit, and indeed the allocation that Devon receives compared to the national benchmarking is over allocation rather than under allocation. There has been a signal as part of these reforms that the continued support in the medium to long term of systems who are spending more than they are allocated will not be continued and supported by Departments of Health and Social Care. So that's a very long-winded answer to say, as things currently stand, we will need to continue to work hard to live within our means without an expectation of any increase in funding other than that national funding for growth that all systems receive annually.
So I note the ICB is about 3 years old. That correct? So
that's correct. Yeah.
So there's only been full years 23, 24, and the last year. Although I can't find accounts for the last year, whether it's got that far through the process for it, it's probably been published, in papers maybe this month or whenever. So you've only got, there's not that many years. And just there's a couple queries on the report. So it talks about the running cost budget and a reduction needed of 33%.
Yes.
So what? Because the total amount, when you look on there's a report. There's your board papers it refers to, and it says total commission services for month 12 of last year of 3,192 millions. So that's 3.2 million, isn't it? So is that reducing is that 33% got to be saved off that? Or is it the running cost budget, which when you look in those same papers at a different section, it says the clusters and mergers have a budget of £18.76. I don't know where that comes from, but that amount per head of population. So £18.76 times by the population of Devon, Torbay and Plymouth, which is about 1.24 million, comes to about 23 million. So this, because there's two things put in, and it's like, it's a bit dramatic, is it not, when you're talking about a £23 million budget or £3 billion budget? It's
Yeah. Thank you, Councillor. Again, really helpful to point out when we've not been clear, because that's our intention, is to be clear to our public and to elected members. So you are right in your supposition that the reduction that is being asked by the government is for a reduction in the running costs of ICBs of 33%. The national indicator of the cost envelope for ICBs now is that £18.76 now increased to £19 due to inflationary costs per head of population. It isn't the same as the money that we have to spend on behalf of the population on health, which is the 3 billion that you described originally. So that isn't subject to the 33% saving. It is the running costs of the integrated care board that seek to commission and to organise that spend as to serve the population, if that's helpful.
So obviously on the bit that says financial position, it still says that further trying to do savings and what have you. I mean, obviously, if we join with Cornwall, or Cornwall and Devon come together, obviously, there's a lot of technology. Obviously, I believe there's already some convergence with some of the back office functions, or having shared services across Devon, and obviously could that be increased across Cornwall as well? What do you think will be the issues in perhaps doing that, achieving economies of scale and merging some of those, I don't know, maybe payroll, or I don't know, procurement's another one they seem to do, isn't it? Or IT system. What do you think are the barriers to achieve getting those things that are non-financial, perhaps?
Yes, really helpful again, Councillor. Thank you for the question. So I think when it comes to looking at the structures of integrated care boards, it's been recognised, as you quite rightly pointed out, that integrated care boards have only been created in statute for the past 3 years. and the approach to creating them was not very uniform, and so different integrated care boards have picked up different functions. This is an opportunity for us to really focus on making sure that the teams that we do employ are focused on the right things, the things that only commissioners can do, to do less of the things that may be done elsewhere, either by our provider partners or by our regional colleagues. So in answer to your question, it will be some economies of scale by combining two teams, clearly can provide efficiency. But it will undoubtedly also involve some tough decisions about stopping doing some things that we traditionally have done and transferring those functions back to our providers in the long term.
Have you got any more questions? No?
Can I just say Kevin Alford has been the chair of the Devon ICB for the last, it's only about 12, well, it's less than 12 months, isn't it? And he's made the conscious decision not to stand again. Obviously, well, I say obviously, what had happened is all the chairs of the ICBs throughout the region were invited to put expressions of interest in, and Kevin made that decision through family reasons, good reasons, that he would not stand. So I think we're at the process now of waiting to see who has got that combined Devon and Cornwall one. And once they're in place, then we've got to look to a chief exec as well. So it's quite an interesting time, Peter, isn't it? Sort of waiting, but the last Devon Integrated Care Board as such will be the end of the month. So it'll hopefully by then we might have a few more answers. And as I say, I sit on there as an observer. So I will let people know what the progress is on that once it's a public announcement sort of thing, really. So but I would like to commend all the staff at the ICB HQ and wherever, they have worked very hard to get this going, and to lose 33% of staffing is a difficult thing, and it will be interesting to see how all the functions are monitored, etc. So a big thank you to all of them up there. They've made me sort of very welcome up there when I go to meetings, and tried to make sure I understand what they're talking about. But I mean, we all know what Plymouth's budget is like to look at once a year in depth. But to see the ICB's budget, I mean, it's quite mind-boggling. And you might think you have a fair number of papers to these meetings, but you go to one of their board meetings and you're talking about a good sometimes 3.5-inch papers. So it's quite interesting to try and plough your way through and understand them. But yeah, so I wish the board well, and certainly Kevin, as I say, has been a great chair. He's been very encompassing of all members. So I personally will miss him in his role, and let's see what comes out of it. But thanks, Peter, for coming today to explain a bit more. See you soon.
Thank you, and I'm sorry I couldn't be with you in person today, but I'm more than happy to come back on another occasion once we know more, to start exploring with you both what that means and how we can seek the support of elected members and the public to achieve our ambitions, which is to create a better life for those that live in Devon and visit Devon and Cornwall and the Isles of Scilly. So thank you very much, everybody. Take care.
Can I just thank you, Peter? Obviously, we need to. Oh, he's gone. Jesus Christ. Jake, when's our next meeting?
It's 14th of September, Chair.
14th of September. I don't know if that's too soon to get Peter back, or do we have him? Sorry?
I think between Gary and myself, we'll find out when.
Yeah,
when
could you? I was going to
that
ask him
is.
that question, but
Yeah.
he obviously was ready to go.
Yeah.
Yeah. Okay. Right, we'll move on to item 9. That was to note that report from Peter. So we'll just move on to item 9, the work programme. So we've got that in front of us. So I'm going to ask members, is there anything in particular that they would like on the work programme that they feel that we need to scrutinise? Mary?
It's not so much a scrutiny, but if we think at the moment about how UHP have got their new urgent treatment centre combined with outpatients coming online, maybe August, maybe September. I mean, many years ago, I can remember going to see how things were managing at emergency department. I just wondered, not so much bringing them to us, whether or not it might be quite nice outside of our meeting cycle to see if we can get a visit up there to have a look around and understand what their plans are. I think that would be quite good, because it's going to be, I say, all singing, all dancing, isn't it, basically, and taking hopefully a lot of traffic away from the emergency department if they don't need to be there.
Yeah, okay, I'm quite happy for that to go on the work programme. I don't know whether it'd be at a meeting though. I think it would be outside a meeting.
Yeah, I think you're right.
I think members, if they wanted to go up and have a look, that would be their choice.
And I think we could link it in with, I know Maria was saying that they've opened an SDEC, and same day emergency care, various SDECs in the hospital, but certainly since we've been looking at palliative care as well as end of life care, it might be quite nice to go on a visit there as well. So I think we could see if we can get a day up there looking at the various bits and pieces, and if people can't go to all of it, they could decide once we've got an agenda where they can go.
Thank you, Chair. Just another suggestion, actually, based out of some of the conversations we had together through the inspection process, was around carers. There was a new carer strategy and a new carers action plan, and I wonder whether that might be something at some point that we could bring back here in terms of on sharing with people, but also to get some check and challenge around that in terms of the work we're doing to support carers in our city.
Mm-hmm. Yeah. I think we need to have transitions to ASC from children's. I think that's really important, and I think that maybe we get that on the next scrutiny, because I think that really is important. And I think also, Gary, I think the PCC CQC outcome needs to be for the next meeting also. I know we could have do we have to have a meeting though? Could we just have a report sent to us? Do we have to really bring that into a meeting? Yeah.
Just Dave, we're very happy, and we put on here to come back. What we don't know yet is when we're going to get our report.
Right.
I've got conversations with them happening this week, where I'm hoping to get a better indication of when we've got the report. From that, we will look at and update our action plan around our response. So I guess I'm very happy if the timing supports it for the next one to come, but I'm very happy we can link in and get that into, as early as we can, and of course we will, and I'm very happy to update people in writing in advance of that in terms of what that's looking like.
Okay, so are members happy for the chair and the vice chair and officers to discuss what we bring into next next scrutiny. I mean, I think we should have the transition to ASC from children's, but are you quite happy for us to make a decision what you can see on there what we need to bring in, and we'll just decide how we bring that in?
The winter plan we've had, I think that's a good thing to have almost like as a standing item for the, you know, because I think that we'll be able to see how some of those improvements of some of like the new buildings and the new, how that will have improved the situation. It might be good to reflect.
Chair, I was thinking about maybe looking at dental services and the dental task force as well, because I do hear a lot from my residents in my ward. We don't have a dentist in my ward. I know a lot of people are the same, and maybe we could look at that through the year.
Yeah. Oh, I'm happy to a suggestion from all members. I'm quite happy for you if you haven't thought about anything today for you to email us and just say, actually, this would be really good if we had that on the work programme. Yeah. Okay. Thank you. And item 10, which is the action log. Remind me where we've got the Armed Forces Friendly GP and Dental Provision Return. Why is that on hold? We've got it on hold there.
Chair, unfortunately, I can't give an answer on that, but I can get Elliot to update you when he's back next week.
Okay, lovely, thank you. It's good to see that. What are we looking at? Yeah, for heavens, it was good. And then that was complete in progress. So is that the Ian Likely? Was that the one that we couldn't? We lost him online, isn't it?
No, it was the first performance report. He was there with Stephen, so I wanted to propose that action.
Okay. Has members got any other items or things that they would like to discuss? No? Oh, brilliant. Okay. All I can say then is this meeting is closed for today. And thank you all for attending, and hopefully see you all next time. Thank you.